Please start.
Good evening, everybody. A warm welcome to all the people present for this presentation for ISA online PG class. So I would like to inform that my name is Dr. Pallavi Bagewadi. I am a senior resident in BIMS Belgavi, and me and Dr. Anusha, senior resident KMC Mangalore, will be the screen coordinator for today's session. We would like to start this session by praying to Goddess Saraswati by playing Saraswati Vandana. Since we have already invoked the blessings of Goddess Saraswati, I would like to hand over the stage to Dr. Bajwa. Over to you, sir.
Thank you, Pallavi. Today we have a very important class. You may not be able to get a long question on this class. You may not be able to get, something, long case also, or a theory question. But this is a very, very important because the obstetric sleep apnea is almost becoming an epidemic now in almost every nation, with the rise in the incidence of obesity and other dietary habits and so many things are there. Invariably, we are called, anesthesiologists are been called to provide the services at the non-operating room scenarios. And it is one where we always do the endoscopies and other procedures wherever we are doing it. So today, what the team which is going to present it, they are doing it like their daily bread and butter. They are very much efficient in that. And our screen coordinators will be introducing the faculty. So I think we have the best faculty in the nation to present this case. And it's going to be a very lively class. So I request Pallavi to go ahead with the class.
Dr. Anusha will be introducing the faculty. Over to you, Dr. Anusha.
Very good evening to all of you. I would like to introduce the faculty for today's session. Dr. Kavita Lalchandani Madam. She is the Vice President of ISA GSB, Professor and Head of Department of Anesthesia at SSGH and Government Medical College, Baroda. With a teaching experience of over 29 years, her special interests are difficult airway, regional anesthesia, and ultrasound-guided procedures. Achievements, she has published a book titled Application of Ultrasound in Anesthesia. She's also worked as a course director and faculty of regional block workshop held at GMERS Medical College, Dharpur, Patan on 22nd December 2024. She was the organizing secretary in the mid-annual anesthesia conference held in Vadodara in May 2024. She is also a ACLS and BLS instructor by the American Heart Association. She is BCLS and CCLS instructor by the Indian Resuscitation Council. She has over 22 publications in various national and international journals. A warm welcome to you, Kavita Madam. Next, I would like to invite Dr. Devyani Desai Madam. She is the Associate Professor at Government Medical College, SSG Hospital, Baroda, Gujarat. With a teaching experience of over 27 years, she has special interests in regional anesthesia, difficult airway research and publication. She was the past president, Indian Society of Anesthesiologists, Gujarat State Branch 2022-23. She was the editorial board member of IJA and IJCA. She has contributed as a co-author for the ISA National Advisory on Perioperative Management of Post-COVID-19 Surgical Patients. She was the organizing chairman in ASDS 2023 and joint organizing secretary ISACON Gujarat 2019 held at Vadodara. She has received multiple awards, the President Appreciation Award 2021 for contribution as a member of the ISA National Task Force COVID Clinical Coordinator. She has received first prize in ISA National Public Awareness Award Individual 2023. She has also received Best Editor Award 2024 from Innovative Publication for contribution towards Indian Journal of Clinical Anesthesia. She has over 30 publications in various national and international journals. A very warm welcome to you, Devyani Madam. Now, I have a small announcement to make. I would request all of you to keep yourself muted during the session, and all the questions can be typed in the chat box, which will be addressed at the end of the session. I will hand over to the faculty now for the session. Over to you, Dr. Devyani Madam and Dr. Kavita Madam.
Good evening, one and all. Respected Bajwa sir and all the teams. First of all, I would like to thank Bajwa sir for giving us this opportunity. The obstructive sleep apnea has, as sir rightly said, it's an epidemic. So nowadays it has become common in obese as well as non-obese patients. And the commonest symptom for the OSA are snoring and excessive sleepiness. But the consequences of these are due to the chronic hypoxia that leads to respiratory and cardiovascular complications. Up till now, the treatment for the OSA is the nasal CPAP. But nowadays, we have started doing this drug-induced sleep endoscopy, and that helps us to find out the obstructive pathology mimicking the natural sleep. Dr. Hetvi Rayani, third-year resident, will present a case here, and we will discuss on that about the pathophysiology as well as the anesthesia concerns. Handing over to the Dr. Hetvi Rayani.
A very good evening to everyone. I, Dr. Hetvi Rayani, third-year resident of Government Medical College, Baroda, presenting on drug-induced sleep endoscopy in patient with obstructive sleep apnea. The patient of ours is 38-year-old male patient, Hindu by religion, occupation is teacher and sedentary lifestyle. Patient came with the chief complaint of snoring since 3 years, mouth breathing since 3 years, daytime sleepiness since 3 years, no headache and difficulty in breathing was present in our patient. The patient has a past history and medical history of known case of hypertension since 4 years on the medication tablet amlodipine 5 mg 1 time a day, while other comorbidities like type 2 diabetes and any other cardiorespiratory disease was not present in our patient. In the personal history, there was significant finding in the sleep. He always feels sleepy and wake up exhausted and associated with daytime sleepiness, and his wife complained of snoring. And as a family history of obesity is present in this patient. In the general examination, the patient is conscious, cooperative and well oriented to place, time and person. The height of our patient was 183 centimeter. The weight is 90 kg. BMI is 27.2 kg per meter square, while no pallor, icterus, cyanosis, clubbing, pedal edema, generalized lymphadenopathy was found in our patient. The patient was vitally stable, but the significant finding was found in the oxygen saturation, where 98% on room air in sitting position, while 94 to 95% was present in supine position. While in the airway assessment, the breath holding time was 17 seconds, while mouth opening was 3 breaths per minute. Then Mallampati grading was 2, neck movement was normal, teeth and TM joint movement was also normal, while significant finding was in thiomental distance, which was 6 centimeter, hyomental distance was 4.5 centimeter, sternomental distance is 11 centimeter, neck circumference is 45 centimeter, and height and thiomental distance ratio was 27.33 centimeter. Neck circumference to thiomental distance is 7.5 centimeter, while upper lip bite test is class 1. While in systematic examination, in cardiovascular system, respiratory system, gastrointestinal system, and central nervous system, nothing significant was found in our patient. This is investigation of our patient, which was all in the normal range. In the CT scan finding of paranasal sinus, there was a mild mucosal thickening in osteomeatal complex with the nasal septum deviation in right side with bony spur was found in our patient. And this is sleep study of our patient in which apnea hypoxia index is 6.7, respiratory index was 10, and oxygen desaturation index was 7.8, while lowest desaturation in our patient was 85%, and the apnea, obstructive apnea was 93%, central apnea is 7%, mixed apnea was 0% in our patient. While a provisional diagnosis is, my provisional diagnosis is obstructive sleep apnea with CT scan suggestive of deviated nasal septum and elongated vulva requiring further evaluation. Thank you.
That was a very nice presentation, Dr. Hetvi. Very good evening, all of you. Coming to the discussion part of our case, let us discuss about the obstructive sleep apnea first. So, Hetvi, can you tell us or can you define the obstructive sleep apnea?
The obstructive sleep apnea is multiple episode of upper airway obstruction during the sleep of the person with the microarousal with or without desaturation of oxygen. This happens because of the various level obstruction like nasopharynx level obstruction, oropharynx or hypopharynx. In the nasopharynx, there can be nasal septum deviation, adenoid hypertrophy can be present, nasal polyps can be present, or in the oropharynx, there can be vulvular soft tissue enlargement, tonsillar hypertrophy can be present in the patient, or rugia in the posterior pharyngeal wall, macrograthia, retinograthia can be present in patient, or in the hypopharynx, there can be omega-shaped epiglottis and laryngotracheal stenosis. All these are causes which will lead to obstructive sleep apnea.
And the commonest site would be?
Oropharynx and hypopharynx.
Yes, these are the most common sites where the obstruction is found. So all these can lead to the symptomatology. So what are the symptoms which we can find in a patient of OSA?
The obstructive sleep apnea symptoms can be divided into two parts, daytime symptoms and the nighttime symptoms. In nighttime symptoms, the patient can have a loud snoring, arousability, restless sleep, mouth breathing can be present, nocturia can be present, or in the daytime symptoms, the patient can have the awake exhaust every time, there is drowsiness and tiredness entire day, or there is headache in the morning, dry and sore throat can be present. Along with this, there can be intellectual and cognitive disability can be present in that patient, and memory disability can be present, or there is sexual problem can also occur in him.
So many of the symptoms were present in our patient as well. Yeah. So usually there are some risk factors which are associated with the obstructive sleep apnea. So can you differentiate? Can you tell us about that?
In obstructive sleep apnea, the risk factor can be divided into structural risk factor and non-structural risk factor. The structural risk factor are micrograthnia, retrograthnia, hypoplasia of maximal or mandible can be present. There can be a tonsillar or adenoid hypertrophy can be present. High arch palate can be present in the child. And in the non-structural obesity, then chronic alcoholic and smoker, or advanced aging, postmenopausal, male gender, or central distribution of the fat can also be reason.
So usually the structural findings which are related to the bony tissues or the fatty tissues, and some other non-structural findings can also be present which can lead to the obstructive sleep apnea. Yeah, and there are some comorbidities are also present usually which we find. What are they?
Mostly the obstructive sleep apnea, the associated comorbidities are hypertension, type 2 diabetes, mellitus can be present in that patient, coronary artery disease can be present in that patient, pulmonary hypertension, metabolic syndrome can be, heart failure can be present in patient, or neurodegenerative disorder like cognitive disabilities can be also present in this patient.
So we should always look for these type of comorbidities when we evaluate these obstructive sleep apnea patients. So before going ahead, let us go with some multiple choice question. First, the first MCQ of our discussion, I think that is related to the OSA and which we routinely use. People must be knowing about it. So the first question would be the stop bank questionnaire, which is used to diagnose, to treat, or to screen for having the risk of OSA, or just to measure the quality of sleep. The answer can be given to the chat box.
Some have written A, some have written C, ma'am.
Yes.
Majority is C.
Majority is C. Let us wait for some time, madam.
No, you can go ahead.
Okay. So majority have given the right answer, that is to screen the patients of OSA for having the risk of having the obstructive sleep apnea in those patients. So sometimes what happens, usually patient doesn't come out with the complaint of snoring and any other symptoms which are related to the OSA. In those patients, when we want to screen, then these questionnaires are very useful. So Dr. Hetwi, can you elaborate what is stop bank questionnaire?
The stop bank question is used for screening of the OSA. There is 8 questions. A high risk OSA patient, if there is answer yes to 3 or more questions, or if the low risk OSA, if the answer yes is less than 3. So first, the snoring. Do the patient snore loudly, which can hurt outside the door, through the door, or asking about the tired. If he or she feel tired of fatigue or sleepy during daytime, or someone has observed stop breathing during his or her sleep, or the blood pressure is high, so if patient is previously taking any medication or is on medication of high blood pressure, or BMI more than 35 kg per meter square, or age is greater than 50 year of age and neck circumference greater than 40 centimeter and gender male.
So many factors were present in our patients.
In
So
our
that
patient,
leads to, yes, yes.
in our patient, the snoring was present, tiredness was also present, plus the patient is hypertensive, blood pressure was also high, and also the neck circumference is greater than 40. So it is greater than 4, so it is high risk of OSA.
Yes. So that is the screening of OSA. So what if we want to diagnose, come to a diagnosis, how will we go ahead?
For the diagnosis, the gold standard is polysomnography. We can do polysomnography. Other than polysomnography, we can do a nocturnal oximetry can be done. CT scan, MRI can be done. Pharyngometry and rhinometry can be done. And then drug-induced sleep endoscopy can be done. And then flexible endoscope with or without Muller manual can be also be done in awake patient.
So can you elaborate little bit on this awake fiber optic nasoendoscopy? What is Muller's maneuver?
In the Muller's maneuver, the patient is asked to close the mouth and do a deep inhalational, which will help to open the posterior airway. And during this time, the surgeon through the endoscope see that by doing this maneuver, this obstruction is relieved or not.
Yes. So basically, it is done in a awake state. So that is how it is different from the drug-induced sleep endoscopy. Now come to the polysomnography. Why it is so important for the patient of obstructive sleep apnea?
As the polysomnography is multimodal, has a multimodal component, for the cardiorespiratory and neurological component are assessed along. So various factors like oxygen saturation, limb movement, electrooculography, electromyography, electroencephalography, electrocardiography, abdominal respiratory movement, and oronasal flow. All these components are measured during polysomnography. So multimodal factors which help to diagnose the obstructive sleep apnea.
Can you elaborate the report which you have already shown about our
Yes.
patients?
In our patient, the apnea-hypopnea index was 6.7. Normally, if it is greater than 5, then we have to plan for drug-induced endoscopy. Our patient is 6.7, so we have to plan for drug-induced endoscopy. Plus, our respiratory index was also 10, which is also greater than 5. And oxygen desaturation index was also 7, and which is also greater than 5. And our lowest desaturation was 85% in our patient. Plus, from the polysomnography, we came to know that is obstructive sleep apnea mixed or central sleep apnea. In our patient, it was 98% obstructive component. So our patient has mostly etiology is obstructive etiology. So for the diagnosis, we can go for drug-induced sleep endoscopy.
These two index, respiratory disturbance index and the apnea hypoapnea index, are they different?
Yes, apnea, mostly in a respiratory index is included in apnea hypopnea index, because in respiratory index it shows the average number of episode the patient has respiratory distress with desaturation.
Yes, and it can also include some another report. It can include some respiratory effort which are not even included in apnea or hypoapnea.
Hypopnea index.
So patient might be having a sleep disturbance, but that cannot lead to the or cannot be because of the apnea or hypoapnea.
Hypopnea.
Okay, so those efforts are also recorded for the respiratory disturbance index. So what is the importance of these two?
From this, we can know that we have to further evaluate the patient for obstructive etiology or not, from apnea hypopnea index or respiratory index.
Yes, even we can grade the patient. What is mild OSA, what is moderate OSA, what is severe OSA, depending upon the apnea hypoapnea index. Okay, and if the patients have already been evaluated or managed according to the respiratory disturbance index from the first time, then even after doing the surgical procedure, the same patient has to be evaluated on the same index, either on the apnea hypoapnea or the respiratory disturbance index. Okay, because little bit difference is there. So there should be no confusion between the two index. Okay. So after diagnosing the patient of OSA, we have seen that the patient is having obstructive sleep apnea. Now, how these patients, after diagnosing, how these patients should be managed, or any other investigation which we can go for the find out the obstructive etiology.
From the polysomnography, as we had found that the patient has some obstructive etiology, we have to see which side the obstruction is. For this, we can go for drug-induced endoscopy. The drug-induced endoscopy means in this patient is given a physiological natural sleep using some anesthetic agent, and during that the upper airway obstruction site or pattern is seen. While on CT scan and MRI and other flexible endoscopy with or without molar maneuver is done in awake patient, while in this drug-induced sleep endoscopy, we have give the physiological natural sleep. So it mimics like a natural sleep. The obstruction can be the site and the type of obstruction can be seen.
Yes, even on CT scan and MRI, that can be done virtually. That can be done same with the airflow. But basically, there are risk of radiation. Here, there is no risk of radiation if we go with the nasal endoscopy. So that is the advantage. Second thing is, it is done as good as in the production with the natural sleep. So these are the two advantages if we go with the drug-induced sleep endoscopy for the find out the where the obstruction is. So what are the indications of drug-induced sleep endoscopy?
The indication of drug-induced endoscopy can be if the patient is not tolerating CPAP, or intolerance to the CPAP or CPAP failure is there, or to see the degree and pattern of the obstruction in the airway, or during this drug-induced sleep study, if we give the change in position, if there is relieving in obstruction, then afterward we can advise the patient for positional therapy, or if we can go do the jaw thrust or stimulation bite during this DICE study. If there is improvement, then we can advise the patient the mandibular advancement device, or by the configuration of the obstruction, the surgeon can plan for which type of the OT he or she has to perform the surgery.
Yes. So how the surgeon has to go ahead, or we can use some device or something like that to improve the case with the obstructive sleep apnea, that can be chosen according to the drug-induced sleep endoscopy. Is there any contraindications?
Yes, there is contraindication. In the drug-induced sleep study, we use the anesthetic agent. If the patient is uh, allergic to any of this drug, then it is one of the contraindication. Or if the ASA 4 grade patient or a pregnant woman are also contraindication to this.
Yes. In ASA grade 4 patient, is it a absolute contraindication?
No, if we optimize the comorbidities, and if it is and to after optimizing, he or she becomes a ASA grade 3 patient, so we can plan after optimization, we can plan for drug-induced endoscopy.
Okay, so if this patient comes to you for the drug-induced sleep endoscopy, how will you go ahead with the evaluation, pre-operative evaluation?
First, we have to take the thorough history of the patient. Physical examination of a patient should be done like we have done in our patient. Then any type of ask the question about any type of comorbidity is present or there. He or she is, or mostly OSA patients are obese patients, so thorough airway assessment is required in the patient.
Yes.
So
Yes.
in airway assessment, we can go for the Mallampati score is present. There are 4 classes, where 3 and 4 classes present. In our patient, it was 2, so it was not a difficult airway from the Mallampati scoring. While the other distance can be measured, like the thiomental distance, which is measured in the extended neck position from the tip of thyroid cartilage to the tip of the chin. And it is divided into 3 grades, like grade 1, 2, and 3, which is greater than 6.5 centimeter. Grade 1, grade 2 is 6 to 6.5 centimeter, and grade 3 is less than 6 centimeter. In our patient, it is 6 centimeter, so it is significant. Then we can go for the hyomental distance, which is from the hyoid to mentum distance is measured. It is also divided into 3 grades, grade 1, 2, and 3, which is greater than 6, 6 to 4.5, and less than 4.5. In our patient, it was 4.5. So it is also some significance is there. And the sternomental distance can also be measured from upper border of manubrium to the tip of the mentum. Here also our patient has 11. It should be greater than 12. It is 11, so it is also significant. And the neck circumference can also be measured, which is also significant in our patient, which was greater than 45 centimeter. And we can also go for upper lip bite test, which is also divided in class 1, 2, and 3. In our patient, it was class 1, so it was not significant.
So what all these findings would have suggested to you?
Uh, all these findings suggest that the patient has a difficult airway. So during the procedure, there can be chance of the difficult airway, so difficult bag and mask or a difficult laryngoscopy or intubation during the procedure can be.
Chances of having the anterior larynx would be more. That can lead to difficult intubation, and
Intubation.
because of the obstruction, there may be a difficulty in ventilation as well. Okay, so this kind of patients, if we are going with the DICE, then what are the investigation and how will you optimize?
Investigation, the other investigation we can do, the complete blood count can be done. If the patient is diabetic, then fasting blood sugar can be done. Then random blood sugar, postprandial blood sugar can be done. Or we can do, if the hypertensive patient, then ECG, 2D echo can be done. Renal function test can, lipid profile. This patient is chronic, then there is inflammatory factor is also present, so C-reactive protein can also be done. And OSA is related to the hypothyroidism, then thyroid function test can also be done in this type of the patient.
Yes, and to rule out the cardiac comorbidity, at least ECG
2D
should be.
ECG or 2D.
Yes, yes, okay. And how will you optimize?
For the optimize, if the patient is any type of comorbidity, we have to first optimize the patient and then plan for the procedure. But in our patient, the patient is non-case of hypertension, but it is controlled hypertension on the medication. He is taking amlodipine. And if the patient is previously on any CPAP therapy, then we have to continue that CPAP therapy and bring that CPAP machine inside the OT. But in our patient, he was not on the CPAP therapy, so it is also not required.
Yeah, so our patient didn't need much optimization. So, madam, let's go with the MCQ first. So we have till now we have discussed about the OSA. Let us go with the first one. After diagnosing OSA with the polysomnography, why DIAS is required? Either to diagnose the site, degree and pattern of obstruction, to assess the utility of positional therapy, to predict the benefit of mandibular advancement device, or all of the above.
Majority have answered
Majority
D.
are yes, majority are in the favor of D. So that's the correct answer. We can do diagnosis, we can do to assess the therapies, and we can predict to assess the usage of mandibular advancement device as well. So right answer, that is the all of above. Can we go to the another question? So does DICE represent the dynamic pathophysiology of OSA, a true statement or a false statement?
Majority have answered true. A.
Yeah. So that indicates the discussion was fruitful. Thank you, thank you. Can we go ahead?
Dr. Hetwi, we have completed the pathophysiological part. Now we move to the anesthesia part. So now this patient is posted for the DICE. So what anesthetic challenges you will have to face?
This is a type of OS, obstructive sleep apnea patient has mostly difficult airway. So there can be difficult bag and mask, laryngoscopy or intubation can be there. Plus the airway shared by the procedure scope. And the second thing is there can be chances of desaturation, respiratory obstruction, or patient can have a aspiration because of the multiple sedative drug use during the inducing the natural sleep.
So what precaution you will take?
For preventing this, we have to give the titrated dose of multiple sedative drugs and titrate according to the BIS monitoring should be done. So there is less chance of respiratory distress and obstruction can occur. And plus, if the patient is on the CPAP therapy, then we have to continue that CPAP therapy, or we can give the high flow nasal oxygen cannula can be used.
Yes, so if patient is already taking CPAP therapy, ask the patient to take it and keep it with him. Okay, we can set in the OT also. Okay, so now what are the goals of procedure for this in sedation?
The goals of this procedure is first we have to give the clear field to the surgeon. So clear field is one of the goals. Second, we have to induce the sedation that as good as natural sleep. It should not be over sedated or under sedated patient. If we over sedate the patient, then it will give the false result or false obstruction. If we under sedate, then during the procedure the patient can be awakened. So the dose should be titrated according to the BIS monitoring. Or we have to maintain a hemodynamics and maintain oxygenation also.
So oxygenation is also important, as well as we have to see for the desaturation episodes also. That is again challenge for the anesthesiologist. Now, how will you proceed for this? So this patient is posted. Now on the pre-operative day, what advice you will give to the patient and how will you do counseling of this patient?
On the day before the procedure, we have to keep the patient nil per hour for 6 to 8 hours, and we have to take a written informed consent from the patient. Plus, we have to counsel the patient that inform the whole procedure should be explained to the patient in the simple word. Like we have to tell the patient that during this procedure the patient is given a natural sleep by the drug, and the surgeon will insert the endoscope from the nose, but he or she will does not feel any painful stimulation during this procedure.
Okay, so on the day of operation, what OT preparation you will keep ready for
On the
this?
day of operation, as there is a chance of the difficult airway, chance of desaturation and obstruction, so we have to keep ready all the difficult cart should be ready. Plus, for fiber optic instrument and preparation should be present there, and airway equipment should be present in the OT.
Apart from that, emergency drugs, HFNO, everything you have to keep ready. It may require for sudden desaturation or any other complications. Okay. So what monitors you will use for this patient? Specify. Yeah.
The monitor mostly required is the BIS monitor is most important during this procedure. Along with this, non-invasive BP, pulse oximetry, and ECG is required for the monitoring of this patient.
Okay. So now everything done, pre-operative done, preparation done. Now what is your plan of anesthesia in this patient?
We have to go with local anesthesia plus sedation. We will
So where will
proceed
you give local anesthesia?
local
Local anesthesia, where will you give?
Local anesthesia should be given in the nasal cavity or oropharynx cavity through atomizer.
Okay, how will you do atomization in this patient, and tell me the dose of that?
Atomization can be done by the conventionally available atomizer, or can we prepare the manual atomizer. In our instrument, we mostly prepare this manual atomizer, in which oxygen tubing is used, a three-way cannula is used, IV cannula is used, and the lignocaine 2%, 4 to 5 ml, which is 5 to 9 mg per kg can be given. So oxygen tubing one end is attached to the flow meter, and 10 liter per minute flow is used, and one end is attached to the three-way, and other end of the three-way there is a syringe, and at the other end IV cannula is used, and through this a spraying is done in the nasal cavity and oropharynx cavity, and properly anesthetize this.
Okay, so now it's a chance of MCQ. Can you put the MCQ? So following are the drug of choice for drug-induced sleep endoscopy except midazolam, fentanyl, dexmedetomidine, or propofol.
The answers are varying,
So,
ma'am. Majority
okay, so answer is, should I answer, madam? Or should we wait? So correct answer is the fentanyl B. See, in this study, we don't want to have any type of respiratory depression. And in many references, propofol is the drug of choice, but we combine it with. So correct answer is the fentanyl. Fentanyl should not be used. It causes respiratory depression and it further deteriorate the condition. So answer is the this fentanyl. Now further going to your plan of anesthesia. So how will you select the drug for sedation? What should be the properties of that sedative drug?
The drug we select should be administered IV, easily titratable, rapid onset, and rapid recovery should be present in the drug with a low residual effect, and inactive metabolite should be less, and plus the cardiovascular and respiratory side effects should be less, and induce a natural physiological sleep in the patient. Such type of drug should be selected.
Okay, so now we start with the pre-medication. So what pre-medication will you give in this patient?
In this patient, we will give the pre-medication like injection ondansetron in the dose of 0.1 to 0.2 mg per kg, and injection glycopyrrolate, the dose of 0.005 to 0.01 mg per kg glycopyrrolate can be given. The glycopyrrolate will have the anti-secretory effect, so it will give the clear field during the procedure.
Okay, so we have given local anesthesia, we have given pre-medication. Now, how will you proceed? How will you give sedative drug? And what OT environment should be there? What type of the OT environment should be there?
We will start the infusion of the injection dexmedetomidine in the 1 microgram per kg over 15 to 20 minutes with the 0.5 to 0.6 microgram per kg per hour infusion is started. Plus the atmosphere of the OT should be all the light should be switched off. Plus the switch off the mobile phone. All the beeps and alarm of the monitor should be also switched off. Plus the outside the OT there should be a board of dice, keep silent, and plus give the patient a comfortable position with the pillow below the head.
So you have chosen dexmedetomidine. Can you tell me why you have chosen dexmedetomidine?
As we discussed earlier, the drug should be selected such that can be administered IV. So dexmedetomidine is administered IV. Plus it induces the physiological natural sleep with less respiratory depression. So we have chosen this.
Okay, suppose you have given dexmedetomidine to the patient, but we have not achieved the natural sleep and still patient is awake. Can we give another drug or what we can do now?
Yes, we can give another drug. Drugs like propofol can be given at the dose of 0.2 mg per kg can be given to this patient, and dose can be titrated according to the BIS value. Our BIS value target should be 50 to 70.
Also, you have to monitor clinically. Also, you have to observe the patient. Okay, so why you have chosen propofol?
Because the propofol can be IV administered, plus it is rapid onset and rapid recovery, and plus its dose can be titrated according to the BIS monitoring.
Okay, now you have given propofol, you have given dexmedetomidine. Now your patient is ready. But when you have taken the patient inside, how much value of the oxygen saturation will you allow to fall? Okay, desaturation value. And after that, you will do some intervention like oxygen or HFNO if required.
In our patient, we have previously seen the sleep study in which the lowest saturation was 85%. So at 85, normally the normal sleep, the patient is tolerated to 85% saturation. So we can allow that much saturation, 85%. We can also further allow desaturation if there is no other hemodynamic changes or complication occurs in the patient.
Okay. Or otherwise, you have to supplement with the simple nasal oxygen, or then you can go ahead. Okay. Can we use propofol alone? Suppose dexmedetomidine is contraindicated. There is some cardiac problem patient has and it is contraindicated. So can we use propofol alone?
Yes, we can use propofol alone, but in the higher dose, which is 0.5 mg per kg. But there is a disadvantage of this. By using 0.5 mg per kg, there can be inhibition of the genoglossus muscle. So there is an obstruction of that muscle. So we cannot know that this obstruction is due to the patient's obstruction or due to the propofol drug we had given. Plus, there is chances of more respiratory depression with this high dose.
Okay, so what are the other drug combinations that can be used for producing sedation in this type of patient?
Dexmedetomidine propofol is one of the combination. With this, we can use the midazolam, dexmedetomidine, and propofol. Then midazolam and propofol can be used, or we can also use ketamine propofol or ketamine dexmedetomidine can be also be used as a combination.
So here, what dose you are using in ketamine?
The low dose ketamine can be used, which is 0.25 to 0.5 mg per kg dose. Ketamine can be used along with propofol or dexmedetomidine.
Okay, ketofol or ket-dex combination. So what are the advantages of ketamine?
The advantage of ketamine is that ketamine is less respiratory depression considering the other drugs. So this is one of the advantages.
Okay. So now we have sedated the patient. Can you show the video how we have sedated the patient that mimics the natural sleep? Can you play the video, Ritvi?
Yes, ma'am.
So this patient, we have given the dexmedetomidine. Monitors are attached. On this side, you can see the BIS value. And so it is like a natural sleep. Patient is snoring and surgeon will do flexible endoscopy in this type of the patient using their endoscope. Okay, Dr. Hetri, what are the likely perioperative complications in this patient, in this type of patient?
The perioperative complication can be oxygen desaturation can occur, apnea can occur, laryngospasm can occur, coughing and gag reflex can be there. There can be arrhythmias, bradycardias can be present, or aspiration can also be present.
So how will you manage?
If there is oxygen desaturation and apnea, we can supplement the oxygen therapy can be given. Laryngospasm, cough and gag reflex can be done by giving atomization of the proper atomization by local anesthetic can be done for this. And if the bradycardia is less than 20% from the baseline, then we can give the atropine. Or for the aspiration, we had keep the patient nil per oral for 6 to 8 hours before the procedure.
Okay, so endoscopy is done. Now, can you show the Watts classification that the surgeon will see on the endoscopy? That is the diagnosis of DICE. This Watt classification is mainly for the level of the obstruction, to identify the level of obstruction. So can you elaborate about this Watts classification?
Watts classification is a velum, oropharynx, tongue base, and epiglottic obstruction. In this, the surgeons see that in the velum there is mostly in the velum there is epilateral or concentric obstruction is present. Oropharynx lateral or concentric obstruction is present. In tongue, only epidirection obstruction or epiglottis epi and lateral obstruction is present. From this, the surgeon so that it is no obstruction, then it is 0 grading. It is if partial obstruction, then 1 grading, and if it is complete obstruction, then it's grade 2 is.
And accordingly, they will plan the further surgery, how to go ahead. Now, what post-operative care? Suppose this procedure is over up till diagnosis. So this patient is to be shifted in the recovery room. So what monitors and what care you will take in this patient?
After shifting the patient into recovery room, first we have to attach the monitors like a pulse oximetry, non-invasive BP, and ECG is to be attached. Then ask the patient to sleep in the lateral position, which will help to relieve the obstruction in the patient. Plus, if the patient is on the CPAP therapy, then we have to continue that CPAP therapy. Or if the patient need the CPAP therapy, then also we have to give CPAP therapy, or other oxygen therapy device can also be given if there is desaturation episode in the patient post-operative as and when required.
Okay, and suppose this patient is to be planned for the surgery. So either surgeon can post the patient immediately, or surgeon can plan for, further after few days. So how will you proceed? Before that, we would like to put the MCQ. So the best way to secure the airway of obstructive sleep apnea patient for corrective surgery is conventional laryngoscopy, video laryngoscope assisted intubation, awake fiber optic, or tracheostomy.
Majority have answered C, ma'am.
Majority have answer C. So correct answer is awake fiber optic, because as we discussed, though airway is normal, but unanticipated difficult airway can be present. So it is always better to do awake fiber optic, or we can also go for the hybrid technique, or we can also, if the patient is to be posted on the operation table, then we can also ask the surgeon to put during fiber optic, they can just put the tube and then we can proceed for the further anesthesia. So now this patient is posted, Dr. Hetvi. So what is your, what anesthesia challenges you will face now?
as this patient has a difficult airway, so there can there can be unanticipated or anticipated difficult intubation or bag and mask or ventilation can be present in this patient. So we have to always prepare for the awake fiber optic intubation should be there.
And also extubation will also be challenging in this
Challenging.
patient.
Yes.
Yes. So what care should be taken while extubation? Perioperative complications remain same as discussed, but the extubation again will be challenging. So what precaution you will have to take during extubation?
This patient should be extubated as and when only all the extubation criteria is fulfilled, then only we have to extubate this patient. And also if we can do extubate this patient by putting airway exchange catheter and then removing the endotracheal tube and giving oxygenation through this airway exchange catheter. So oxygenation can be done with this catheter, and if there is any desaturation or any airway obstruction or any complication happen, then we can again intubate through this airway exchange catheter, and oxygenation can be done through this.
And the HFNO should always be kept ready in emergency cases. Okay. And post-operative course remains same as in DICE patient. Now, Dr. Hetvi, can you enumerate the different types of surgery which are being done in our institute?
In our institute, the various surgeries are done is a functional endoscopy, septoplasty, turbinectomy, adenectomy, tonsillectomy, vulvopalato-pharyngoplasties. All these surgeries are done in our institute.
Okay, so from this slide, we can see that the majority of the surgeries are not that much challenging. The most challenging part is for our anesthesiologist to maintain the sedation for DICE, like Dr. Hetty mentioned very well, that patient should not be under-sedated or over-sedated. So it should be adequately sedated patient and no respiratory depression. Drugs should be used. And last slide of the video, we have that how they have performed. And in this video, we will see the different maneuvers we have also done, and the surgeon has done this functional endoscopy continued. So can you play that video, Dr. Hetvi?
Yes, ma'am.
Here you can see there is a collapsibility of the upper airway, and during snoring there is a collapsibility that causes obstruction in the upper airway. Now we are doing some maneuvers like jaw thrust and nasopharyngeal airway that will be seen.
Good, I suppose. V2 O2 T0 T0. Ma'am, can you do a smart job? The complete photography. So wait till he snores. When the base goes below 65 mm, then that's the time it starts snoring. Follow. Stop. Pull the jaw.
So here we have done the jaw thrust, and surgeon is again assessing the airway. Thereby some relief is there in the obstruction.
Okay.
And also another maneuver we have done, we have put the nasopharyngeal airway. Again, there is an improvement in the obstruction. So, Dr. Hetvi, can you show the references which have used for this discussion?
Yes, ma'am.
these all are our references, and we conclude the session, and question answer are open. Thank you, sir, and all the team.
Thank you, ma'am.
Are there any questions?
Are there any questions in chat box?
As of now, nothing is there, ma'am.
Ma'am, you have spoken on a very different kind of topic. Your case discussion was,
Okay.
and it's actually obstructive sleep apnea is a very common thing, as Sir Bajwa sir said just now. But are you doing this technique in your hospital life?
Yes, madam.
Yes, madam.
We in the last slide we have shown these surgeries which are done after DICE.
So is this better than, do you rate this better than polysomnography, which is said to be the ideal for the diagnosis of obstructive sleep apnea?
See, in simple cases like some we can diagnose with the polysomnography and in CT scan. Like this deviated nasal septum is there, turbinate enlargement is there. In such cases, DICE is not required. But in certain cases, we don't come to the conclusion, and then we have to go for the DICE. So it is not recommended for all patients. They have to filter according to the pathology on basis of polysomnography and this.
And polysomnography is not available also everywhere, and it is a costly affair. So I
Yes,
think
madam.
this technique is much better than that.
Yes, but there are 3 levels of polysomnography. So third level, that is nocturnal oximetry, that can be done at the home. That is the easier way to do the polysomnography. Others are being done in the laboratory. So one person has to remain awake throughout the night. That is called level 1. That is difficult. But nocturnal oximetry, that was discussed in previous slides.
Yes.
So that can be done, and that is the easier way for the diagnosis.
One question to Dr. Hetvi.
Yes, ma'am.
Madam asked you about the like if this patient is taken up for some kind of surgery, right? After establishing the diagnosis of obstructive sleep apnea, if the patient is taken up for some surgery, she asked you how you're going to secure the airway, right? The methods of induction. So you said, what did you say? Awake fiber optic bronchoscopy.
Awake.
Then say
Awake fiber optic or bronchoscopy can be done, or we can go for video laryngoscopy also along with it.
Video laryngoscopy assisted. Yeah.
So I just wanted to ask you whether you can do the technique of awake video laryngoscopy. Awake video laryngoscopy.
Dr. Kavita madam told, Dr. Madhuri, Dr. Kavita madam told it's a hybrid technique. You can also you can combine the video laryngoscope with the fiber optic. And that is the technique used worldwide now. The hybrid technique has overtaken the simple fiber optic or alone. And when you're going to the diagnosis of all the sleep obstructive apnea, sometimes it's not feasible to diagnose the case with the fiber optic also. You have to see which anatomical structure is there. So hybrid is going to be the D technique in the future for diagnosing this case on an endoscopic basis also.
Yeah. No, I was just going on to, like, once the patient is diagnosed, then you know for granted that the patient is having OSA. So that time you're taking up the case. So this technique of awake video laryngoscopic intubation is very useful, where there is adequate space to do suctioning and to spray the local anesthetic also on the glottis.
Yes, madam, I got your point. Yes, madam, I got. After giving local anesthesia, we can also go for the video laryngo because we have adequate mouth opening. Yes, definitely. That can also be done.
Yes,
madam. Yes.
We have a question in the chat box. OSA screening in pediatric patient and anesthetic management for the same.
I think before that question, I will ask the question, what is the actually incidence of OSA in the pediatric patient? That's more important before we go for the diagnosis also for this thing. I think incidence is very important. Have you come across the pediatric patient with OSAs?
Not at present, sir. Not yet now. But,
because the structure, see, in the pediatric patient, only with the pathology with the macroglossia, something like that, only you will come across those patients only. But those patients which have a pathology where any pathology is present in the oral structure, that is can always present, but I think those will go to the indirect laryngoscopy in the ENT OPD also, whether you come for the tonsillitis or come with adenoids or adenoid tonsillectomy, patient coming for those. So those are not typical OSA. The OSA part is basically the tongue, the genioglossus, the base of the tongue, which is obstructing the
Yes, sir.
the adenoid and tonsils are a pathological entity which may or may not exhibit into the obstructive sleep apnea. So those can be little bit of harsh sounds always coming out. So I think in those cases, the diagnosis is always certain when they come to the ENT OPD. We are having class of endoscopy based, diagnosis with the sleep apnea in these cases. So that diagnosis is already done in the ENT OPDs wherever the ENT surgeons are there.
And usually the
And sir,
structural
incidence of
pathology are most of
pediatrics
the
during.
time evident, sir.
Yeah, invariably there are so many clinical symptomatology because the typical age group is there. Where the
Yes, yes.
tonsils adenoids are there, so typical age group is there. And I think whenever they go to the OPD of the ENT specialist and hardly come for the endoscopy diagnostic or something with the OSA. The
Yes, sir.
pathologies are basically there. Pathologies, the macroglossia, some endocrinal endopathies are there, where I think you can always have the large tongues where they can have those pathologies. So real incidence, I just noticed Dr. Lalit sir had 1 to 3%, but I think even that also must be going with the how much is the real incidence of what pathology. That is very, very important.
Yes.
Sir, exact and incidence we don't know, but snoring is more in pediatric patient, but they do not require dyes. As you said, that is mainly because of the tonsillitis and enlarged adenoids. And as you said, it is everything is seen very well. So dyes is not required. And up till now, we have not come across any pediatric patient. We have done all the adult patients of the dyes.
Because adult patient already the growth has taken place of the hard structure, the bony areas, and
Yes,
now the circumferential growth of the soft
Yes.
tissue. That is basically going to lead in the pediatric patient.
yes,
The age is still growing up, and I think that compensates also to the
Yeah, yeah.
anatomical structures inside
yes,
the
sir.
oropharyngeal cavities.
Hmm.
That is another factor which is preventive to the OSA in those patients also.
And the bony abnormalities in adult that needs correction. If the central pathologies are there, then we have to go with other therapy like CPAP and all this. But the bony corrections are required for this for corrective surgeries. Bony
And how
pathology.
many cases you do almost every day or a weekly
No,
basis?
no, sir, not that much. Up till now, around 20 to 30 cases we have done for the dice. Not on daily basis. In between there were daily one case, but now again there is a pause. So it like that.
Okay. Anusha, Pallavi, any other question? Is there in the
There
chat
is a
box?
question saying that are you comparing endoscopic pharyngeal diameter before and after sedation? And also, what is the level of pharyngeal collapse?
Yeah, that's very good question actually. And that also depend upon the dosage, how much dosage you really want to give and how much the tissue
Yes.
relaxes sometime. And
Yes.
that was another thing where the discussion began regarding already anticipated cases of OSA going on the operation
Yes.
table. How are you going to deal with these cases? That means how much of anesthesia drug is really going to relax the pharyngeal oropharyngeal tissues, which are really going to cause OSA. So that is, I think the titration of the anesthetic doses is very, very important, where you already have done endoscopy, you have
Important.
identified the structure, the airway difficulties anticipated. You go with the titration of the technique and choosing on the other side the equipment of a hybrid technique and anesthesia titration. That's the way to go forward. I think Dr. Kavita Madam will say more
Yes, sir.
things on that.
Yes, sir. Yes, sir.
And
No,
and
that
and
is true.
sir, one more. Basically, we are not measuring the diameter, but we are seeing what is the either the lateral wall pharyngeal collapse or the concentric collapse. So all treatment sometimes it is based on the type of obstruction rather than the diameter
So, so
or
I
the
think
structures which are involved.
Another question will come from somebody. They will say whether the airway ultrasound is important, where you can see the
Yeah.
three-dimensional picture
Yes,
of the.
definitely,
Yes,
sir.
yes, yes,
Definitely, sir. Airway ultrasound is definitely helpful.
Yeah.
But here in all patient, we anticipate it as a difficult airway only. And we have not put ultrasound airway here because this case we have taken retrospectively. So that's why we have not kept this ultrasound assessment. Otherwise, we can definitely go for the ultrasound assessment, and sensitivity is definitely high in ultrasound airway assessment.
So I think, ma'am, during diagnostic studies also, when you are going for the diagnosis of the abnormality, what type of
Yes, sir.
abnormality is there, even then I think you will be able to come across that these patients are going to be more tougher. They are having more collapse during the full GA. So I think that
Yes, sir.
you can also, to some extent, combining your clinical acumen and then your this one technical diagnosis. I think you can always say that these patients are going to be more tougher when they're going to be taken up for the corrective surgery.
Surgery.
Yes, 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 yes.
Sir,
Definitely, sir.
one patient we have faced the problem also. It was intubation was very difficult, and patient went to arrest, then recovered also. We could intubate, but it was real challenging. So awake fiber optic should always be considered in this type of patient for induction.
Yeah, with the learning hands also, with the learning curves.
Yes, sir.
And
Yes.
with the
Yes, sir.
techniques, I think people will come up with the different questions. Say, with this, which type of video laryngoscope is best in this type of patient, and another
Yeah.
method of questioning. But I think with the availability of the
Awake,
video laryngoscope and
yeah.
fiber optic with your side, I think
Yes, yes,
you are the
Yes, sir.
best person to go ahead with these type of cases.
yeah, yeah.
And expertise also, in which you are
That's what I
expert.
said, ma'am.
So that,
Learning curve is, it depends upon the person who has done it multiple times.
yes.
They will be easy to prevent any morbidity on the table.
Yeah.
Yes.
Any other question or any other suggestion or feedback? You can raise your hand or you can unmute yourself and you can ask our eminent teachers here.
There was a comment in the comment section. In adult, also adenoids are observed at the age
Yeah.
group of 24 age.
Yeah, few cases
Yeah,
we
yeah.
have seen. We have got the surgery also done,
Yeah.
but I think that is not a common cause of obstructive sleep apnea. Those are the pathologies we always have encountered. I think even the last 1 year also, I have done 2 to 3 cases of surgery for adenoids in the adult patients also. But if you ask me, OSA is very, very rampant nowadays.
Yeah,
Yes,
Especially
yeah,
in
sir.
the northern part of
yeah.
the country, you can see many patients with the OSA.
Yeah.
Even non-obese patients also.
Even non-obese patient, that's true. Yeah, Dr. Madhuri, you want to add something more?
Yeah, ma'am. Like, I have not understood that. See, these patients, you are already doing the stop bank questionnaire in these patients before you take them up for drug-induced sleep endoscopy, right?
Yeah.
Yeah. So, is there any particular stop bank score beyond which you take up the patient? Like, are there any criteria for that?
If
Especially
patient
Something
for
like
falls
that.
into high,
drug-induced
yes,
ma'am,
Dr. Devyani.
especially for dice.
Dr. Devyani, you want to say something? You say something first.
Yeah, especially for dice. That's what you want to ask, ma'am?
For dice. Yeah, for dice.
No, madam. It is not basically the any cutoff point that beyond this we have to go for the dice. It is not like that. After just screening, every patient went for the PSG, and then only we had taken them for the dice. So only from the stop bank questionnaire we didn't go for dice directly.
Okay. But what were the indications for taking up for dice like?
Basically, if we see the PSG report, if they find any obstructive pathology, like the apnea, they have already mentioned, it is an obstructive apnea, mixed apnea, or central apnea. So, if the percentage of obstructive apnea is higher, they would like to go for the dice first.
I think Dr. Apesh Patwa has raised his hand. Sir,
Sir,
wants
Hetli, can you put the polysomnography report? So from that we can explain in better way. What are the
Yes,
things
ma'am.
we see in the PSG?
PSG
So
report.
Hetli, please put Report.
Put that slide again.
Yes, ma'am.
Could I speak?
That slide.
Ma'am, till that time, Dr. Apeksh and Lalit.
Yeah, Dr. Apix. Yes.
The
Yes,
screen
thank you.
coordinator, you should be active. If somebody has a question, you
Thank
just open the questionnaire.
you, ma'am, for giving me an opportunity to speak out. Actually, the reason of doing DICE, this was in relation to the previous discussion. Mainly, ENT surgeons are doing a DICE to identify the level and severity of obstructions. And depending on that diagnosis, suppose it's a base of tongue soft tissue and it's creating obstruction. So they are deciding about which type of surgery is required to overcome this obstruction. That is the main purpose of doing DICE. Suppose it's a palatal obstruction, so they will do a palatoplasty. If there is a base of tongue obstruction, there is an accumulation of adipose tissue at the base of tongue. They remove the adipose tissue from the base of tongue. So the main purpose is, rather than diagnosing the OSA or severity of OSA, is because deciding which type of modality of treatment these persons require. For that, they are mainly doing the DICE.
Yeah, true. I think that's what they said in the beginning only when the class was started. So they said doing it for the diagnosis of the level of obstruction, the
Obstruction.
type of
Yes,
obstruction,
yes,
and how that surgical correction to be made. I think that it's basically helping the surgical decisions here. These type of procedures.
And other thing, what happens? Suppose we have identified during the DICE that this person is having collapse, sort of 30, 40, 50% lateral collapse or anterior posterior decrease in the depth of pharynx. So if this type of patient require in future coming for the anesthesia, we are knowing that with the sedation only, this patient is going to have obstructions. So we have to start with the CPAP during the pre-oxygenation to prevent the further obstruction, specifically when anesthesia management is concerned, non-related to OSA surgeries. If this patient come for the other surgeries, so this is very helpful for us also.
Yeah, true. You will buy a time, we will pre-oxygenate the lungs. If any time is spent on securing the airway, whatever technique you are going to use, a big fiber optic or a video or a combined hybrid, I think the CPAP in the beginning will definitely give you a more ample time
Yes, sir.
to oxygenated lungs. So that is a good point.
definitely. Yeah.
Dr. Lalit also raised his hand at that time. Dr. Lalit Prayagar sir, kahan
Yes,
gaye?
sir. The same Dr. Patwaz mentioned, that is for the surgery procedure that can be done according to findings in the DICE.
Yeah.
The HFNC is better than the CPAP because during that HFNC, we can able to continue the procedure also.
Sir, HFNC or CPAP, anything we can use. It's not like that. If patient is already taking CPAP, then we can also, and HFNC is also good.
Should I?
We can use anything.
See,
Yes.
sir, in high frequency nasal oxygen,
Bronchoscopy.
sir, the collapse is there. Suppose the collapse is there, the volume of the, giving it by the HFNC is not going to be optimal because already the soft tissues have been collapsing. And I think
Yes, sir.
how much degree of
CPAP.
high flow can be given to at least oxygenate the lungs. I think CPAP, sir, it will give a support to the oral structure also to some extent, oropharyngeal also, so that it
Yes,
keeps
sir.
opening the airway till the last almost bronchial. So I think, sir, CPAP may be having a little advantage over the high flow nasal oxygen.
But at that time, we have
Hi.
not.
But in emergency, we can use HFN. But sir rightly said, CPAP would help definitely for this.
Dr. Pex, want to add something more?
Yes, sir. Thank you. Thank you again for giving me opportunity. See, whether to decide to go ahead with the CPAP or HFNC. Suppose patient is already having a diagnosis of OSA and patient is on CPAP of 5 or 6. Then you can use HFNC with 60 liter of flow because 50 to 60 liter per minute humidified heated gas with the closed mouth can generate about 7 to 8 centimeter of STO CPAP. But if patient is requiring the CPAP more than 7 or 8, then HFNC is of no use. So when patient is on OSA, patient is having OSA and on CPAP more than 8 centimeter of STO, then application of HFNC not going to maintain the integrity. So that's very important. So 60 liter per minute, closed mouth, 7 to 8 centimeter of STO with HFNC.
That is almost coinciding with the physiological internal peep also. I think that's a good point again.
Sir, one thing I was wondering with the HFNC is that HFNC will work if there is no obstruction. If there is obstruction because of the fall of the pharyngeal structures, even 60 liters may not be very helpful, even to get that CPAP of 4 or 5 or 6, whatever we want. So if the tongue is falling back, do you think the HFNC will be very useful in those
That's what I
cases?
said, Dr. Nishan. That's what I said. It depends upon individual variation also. What is the level of obstruction? What is the degree of obstruction? What is the laxity of soft tissue undergoing anesthesia after anesthesia is administered? So that's why the CPAP holds advantage over the high flow nasal oxygen, because this is something very, very physiological. And if you take it a physical way also, that is going to decide about the oxygenation of the lungs. So I think CPAP is always be better. And rather than we experimenting with the high flow, and I don't think so high flow nasal oxygen will be comfortable every time. The amount of oxygen going to that much, wasting the oxygen also, where we can easily use the CPAP. It's a more definitive pathway going forward to secure airway in such patients. I think already we have anticipated, OSA is anticipated. The degree of difficulty is there. Everything is there in the algorithms. So better go with the techniques which are time and tested here in these type of patients, rather than just we seeing that is a better or something better. I think even Kavita madam and Dr. Devanis, I can also devise a study also, a comparative analysis between these two techniques.
Yeah.
Yes, sir.
The OSA
Yeah,
undergoing
sir.
dice and something like that.
Uh,
We can give a better data also. Real time data also can be generated for that.
yeah.
Yes.
Yeah. We'll try that, sir. Definitely.
Dr. Madhuri has raised hand without any picture. Madam, your picture gone.
Yeah. No, I just wanted to say, ma'am, that you all said that ketamine you are using for sedation for this. But most of these cases may be obese with obstructive sleep apnea. They will also be having pulmonary hypertension. So in spite of that, are you all using ketamine or low dose
Madam,
ketamine
we
you are
have
using? Low dose
low
is
dose
okay.
ketamine, and that is used along with either propofol or dexmedetomidine, where dexmedetomidine is contraindicated, like in cardiac patient, hypotension, bradycardia. So better to we
Okay.
can go for it. It was an option, but usually in our routine protocol, we are starting with the dexmedetomidine and then followed by propofol
And
as
have
well.
you encountered any problems post-operatively in your cases?
No, madam. After patient fully become conscious, we shift the patient in the recovery room and we put the monitors, but there's no problem.
Okay.
Usually with the short-acting drugs, patient recover very well.
Yes, ma'am. No, this is only for the benefit of the PGs, that whenever there's such a case of obstructive sleep apnea, post-operative vigilant monitoring is very, very
Yes, madam.
important, because
Yes.
people
Yeah,
have lost cases because of lack of monitoring and
No.
leading to respiratory problems. Especially the arousal response to hypoxia will be a problem here. So
Yes, ma'am.
monitoring and opioid-induced respiratory depression is also very high
So, madam,
incidence in these cases.
here that's
you
why
have to
I asked the
avoid.
question that opioid should not be used
Yeah.
in these cases. And in recovery also, if patient is already taking CPAP therapy, then it should be available, and as and when required, CPAP should be
Yes.
given to the patient in post-operative period.
Yes.
So there won't be any chances of
And
complication.
with the head up tilt, 25 degrees.
Yes, madam.
yeah,
Yes, head
yeah,
up.
yeah.
Yes.
Yes.
Yes,
Yeah.
madam.
Madam, Kavita ma'am.
Yes, sir.
So a very nice class, a different
Thank you,
type
sir.
of topic. So you have led your team
Thank
very
you,
well
sir.
in presenting this class. So you can see my screen.
Yes, sir.
Your
Thank
name
you
is
so
flashing
much.
there. Your name is flashing there as our esteemed faculty for this class. Thank you very much, ma'am, for preparing the team. And
Thank you so much, sir.
equal thanks to Dr. Devani Desai, madam. She
Thank
has
you.
done a wonderful work in preparing the PG student as well as preparing for the class. Absolute good topic, and we are really got wisdom today in this field.
Thank
And
you so much, sir, for giving us the opportunity.
yeah,
Yes,
Hetvi,
sir.
you have done well. Hetvi was very confident. I think that also reflects the hard work done by the teachers. If the third year PG student is very confident about almost everything, so that means the study culture is a very good going in that field. So good,
Thank
Hetvi,
you, sir.
keep it up.
Thank you, sir.
Thank you, sir.
And
Thank you.
Pallavi is our screen coordinator. So Pallavi and Anusha both. Thank you very much for keeping up with the good anchoring in this class. And I think these are the youngsters and then the PG students, so they always keep these classes alive. So I'm very thankful to all these people, especially then our class coordinators also, Dr. Madhuri, Dr. Nishan, Dr. Ridhima. They keep on preparing these classes, and all the classes go very smoothly. Dr. Shobha want to ask something. Madam also. Shobha madam, unmute.
Sir, yeah, excellent discussion. Like I want to know whether the shoulder extension will help to relieve the obstruction because this is what the trick I try in the MRI when I put on the propofol drip and I give dexmedetomidine and I want to keep the patient under without any mobility in the MRI suit. So I do a shoulder extension with the oxygen on, and that's what the this one
Madam, I think this is a good
procedure we
question
follow.
and good question. Actually, they have already given that answers to some extent in their presentation.
Yes, yes.
Whenever these cases come over the OSA, I think whatever the basic maneuvers of airway management are there, we always apply those maneuvers. It is above those maneuvers that if they are not helping, that how the OSA is going to cause more obstruction in these patients. I think whatever the shoulder extension or a neck extension, whatever the procedures I think which are normally recommended for the airway management, those I think even for the DICE procedures, even they can must have done those procedures also. I think the OSA goes beyond that because those are the conventional procedures where we keep the airway intact, all the three axes aligned to each other. But with the OSA there, I think it's a further pathology, added pathology to the maneuvers, which they may not be completely, helpful in securing the airway. So definitely with this patient going for the MRI, it will be a risky procedure. I think in such patients with a history of OSA, it's better to take services of Dr. Kavita and Dr. Devyani before you take a note to go further for the MRI. That is away. It's a non-operating room anesthesia is always challenging. It's a difficult
Yes, sir.
question is good, and I think for that you can have some sedation under if you have a good I think side by room during the MRI suits. Na? That's the best way. I think those are the real tough cases to handle. What is the take of Kavita and Devyani Sai, madam?
Yes, sir. I'm
Yes, sir.
managing with
Yeah.
my this technique, sir. I'm managing all MRI for last 10 years. So this is what the protocol I follow for an MRI without any intubation, without any element.
Ma'am, it's
Of course,
okay.
not all for the OSA, but the obese patient and even the children.
Yeah, ma'am, I think it's always fortunate that we don't encounter such cases during the NORA. But the patient with the OSA have a different degree and variability whenever they get the sedation or a GA in different circumstances, and how they really behave in those settings in the out of the operative room setting, and how are we much capable of handling those things. I think whenever we are going for the NORA, we should be capable of handling any situation arising, especially the airway management.
Yes, sir.
So, because the patient safety is the foremost, and we should be very, very careful. And anyway, we are always fortunate that anesthesiologists are always very hardworking. They keep everything ready with them because they
Yes, sir.
have the most anticipated. They always anticipate these type of obstructions and complications during the such procedures. And I think Dr. Kavita madam, Dr. Devyani Sai madam, you can answer how you can this DICE as well as the other techniques can help in deciding about the NORA in these type of patients.
I think if the dyes can help us about the pattern of the obstructions. and especially at the level of the obstructions, the site basically. So if we know the site of the obstructions, accordingly the maneuvers can be done. Like in case of the base tongue obstruction or something like that, the nasopharyngeal airway would be very useful if we use it in a MRI or a CT scan like that. So this kind of things can be definitely useful before we go ahead with the NORA in OSA patients.
I think nasopharyngeal airway is always a better,
definitely a very
first-hand technique to overcome these type of things.
Yeah.
Sometimes the maneuvers may not be possible in the MRI
Yes.
suite.
Yeah, because we are away from the patient, so might not be possible for us to do.
Dr.
There
Atul
is
had raised
last
hand.
one question.
Dr. Atul,
Yes,
you want
sir.
to ask something?
There is one last question, ma'am, if there is
एक
time.
मिनट, Dr. Atul की बारी थी, उन्होंने हाथ खड़ा किया.
Finish up question. I want to just thank you for what. Then I will talk later. First finish the question.
Huh?
Question खत्म कर देते हैं, बाद में लेते हैं.
What is the question, Madhuri madam? What is the question?
The question is, will early morning ABG and PaCO2 help decide the severity of OSA?
Yes, that can be helpful.
That's the baseline. I think
That is the baseline.
always help.
Yeah.
Baseline always help. And how you can always compare the baseline with when the obstruction occurs. That can be a very good study also. That how much of degree of obstruction is there. It will augment the diagnosis as well as the need for the correction of the surgeries.
See, before going for DICE, there are so many things we can do. DICE is the last thing which we go for. And when we don't find the obstruction during this natural sleep. So DICE is a dynamic study. Okay, so all these are definitely helpful. Polysomnography, ABG, everything is definitely helpful. But DICE is the last thing which we go for that. Any other questions?
No questions, ma'am.
You have silenced everyone, ma'am. You have given all the answers to everyone.
Sir, from Gujarat and bottom of my heart, thank you very much, sir. Bajwa sir, especially because of you are giving us a chance from national level for national level presentation of these PG courses lectures. Thank you very much. Again, sir, I request more 2-3 medical colleges from Rajkot. Also, the one of the good is IKD. That's the Indian Institute of Kidney Science and Disease. So they are also preparing. I will send the data. Whenever take an opportunity, we present from the national level. So
no problem. That is not an issue. Actually, we always give a journal rotation, but somehow the Gujarat classes were not there during the first year of my tenure.
Yes,
very few classes. So then I think actively. So it has to be a balanced approach throughout the country.
Yes,
and especially we try to take those colleges which are lesser here at the national level. They should come forward with this class. Talent is everywhere.
Yes,
so people like Hetvi, they're studying in this SSG, and see the level of confidence. So you can see it's not the higher premier institute, but every medical college has got a talented people, talented teachers. So we are giving a chances according to that. So it is not, we think of entire India, not just Gujarat. We think
yes, sir, I agree with you, sir. So that's, I don't just, I will give the list whenever you
sure.
you can, yes,
don't worry, Dr. Rasis is also there. He want to speak something.
Yes.
He's waiting for a long time. Dr. Rasis, Diwan sir, for this class, unmute yourself.
Thank you, sir. Actually, my voice has gone a little bit talking for last 3 days. But on behalf of Gujarat, like Atul, I also thank you for giving a lot of opportunities this time to many medical colleges in Gujarat. And it was a very good discussion led by the National Committee, Central Committee, you and Dr. Kodi and everyone. So very happy to have this situation.
Thank you, sir. Thank you very much. Any other, Anusha and Pallavi, any other question left?
No, sir. Questions are done, sir.
Yeah, great. So
thank you, sir. This was opportunity for PGs as well as faculties. So it was the PG class, but it was also opportunity for us.
Yes.
And we have also learned. And thank you so much, sir, for giving us this opportunity on this national platform.
These classes actually, it's not just for the PGs, it's for the teachers also.
It is for teachers also, definitely, sir.
So nobody is perfect. So what we during discussion we come across many such points which when you imbibe in your curriculum, your teaching becomes more better, precise in the PG
definitely,
students.
sir.
And these classes are always available on the YouTube. Today, I was asking one of the student, the first year PG student, can you believe this? I think just only 3-4 months, I think they have inducted into the PG courses, and they are watching the classes on the YouTube.
Yes, sir.
Yes, sir. Even we are watching sometimes if we want to see the.
Sir, also in the private practice, we are needed. This is
Yeah, for practitioner also is very important. Yeah.
Yes, sir.
Yeah. So thank you everyone for
Thank you,
joining
sir.
this classes today. Next Monday, we will have a very, very special class. So I will be the moderator in that class, and the
Oh,
speaker will be the
Definitely
President
we will
of
join,
India.
sir.
ISA President, Dr. Bala Venkat's class will be there. Myself and Dr. Divetya sir will be the moderator in that class. So that class will be one of the very important class. So
Very
nobody
important
should
class.
miss that.
Yes, sir.
Definitely.
Yeah.
Yes, sir.
Thank you. Thank you very much, sir.
Thank you, sir. Thank you, madam.
Thank you,
So
sir.
good night,
Don't be-
everyone.
Good night.
And
Thank you, sir.